I'm here with Sam Garg, chair of the ASCRS Young Eye Surgeons Committee. Sam, you gave a wonderful talk. So let me just sort of set this up in a manner that comes into my office very frequently, which is this. So a patient comes in for cataract surgery. I know that the patient needs cataract surgery. There's no retinal pathology. The patient's got a cataract. The patient needs cataract surgery. The patient has mapped out fingerprint dystrophy, as a lot of my patients do, or some other surface pathology. I am telling you, visually, the mapped out fingerprint dystrophy or the mid-peripheral nodules, they're not playing any role in the patient's vision. Take that as a given. Okay. Do I have to deal with them, or can I just do the damn surgery?
So first of all, thank you for having me. I would say to take a step back, and you don't know for sure if it's not affecting the vision without getting some testing. And the testing is a topography. Either there's multiple topographers out there. We use a pentacam. We also have ones that give us a placido disc image. And looking just at the numbers and looking for agreement amongst the numbers by themselves doesn't give you the full picture. So you really want to look at the raw images of the topography and make sure you really inspect the what the topography looks like, because even though you think it may not be playing a role, it probably is to some degree. And if you're talking about various lens options, or if you're trying to get a particular target, it should be something you should at least address with the patient and let them know how that may or may not affect their outcome.
Great. So I have, and this is you've seen patients like this too. I'll do well, forget about the topography. A patient comes in with mapped out fingerprint dystrophy, and I do the toric lens calculations, and the patient calculates out to a toric lens. Mm-hmm. Now, his spectacles don't have cylinder. I understand they may reflect the person that he saw last, or the axis is just substantially different from that axis to which I manifest mm-hmm. the patient. And I'm willing to ascribe some of that to the mapped out fingerprint dystrophy. What the hell do I do about it?
Yeah, so in these patients, I think doing actually a superficial keratectomy is helpful, and not just for mapped out fingerprint, but really important Salzmann's nodules. A lot of people see those nodules and are intimidated by them, feel like if it's there, I'm just going to leave it alone and pretend like it's either not going to make a difference, or you try to calculate for it, and if they change with time, and have the patient deal with it. But really a simple technique can be done at the slit lamp very easily. I put a speculum in the eye, topical anesthesia, a little bit of antibiotic, and if it's a Salzmann's nodule, I'll take a jeweler's and just try to find the edge, and they usually come off in a nice plane. And then I'll take a 15 blade and just gently, without violating Bowman's membrane, go ahead and clear off the visual axis. And you want to make sure that you go through the visual axis, because sometimes when the epithelium comes back in, and if there's sort of older epithelium with maybe some basement membrane issues beneath it, and the new epithelium, you do get irregularity there, and it takes a while for that to normalize. Whereas if you take all of the epithelium, especially over the visual axis, the healing is much more normal. The keratometry normalizes more quickly, and then you can make a decision based on toric lens or not, monofocal or not. Do you even consider doing any kind of presbyopia correcting lens?
How do you have that conversation with the patient?
Yeah, good question. So, I typically, use the classic camera analogy to describe what's going on in the eye, and I explain to them that the cornea focuses about 2/3 of the power is the refracting 2/3 of the light coming into the eye. So really, it's the dominant optical element when it comes to focusing. So we really want to make sure we optimize that and try to regularize that as much as possible, so that when we do cataract surgery, we're able to target to the best of our ability.
And then, I mean, if anything, it's going to build confidence. I think that in the confidence that the patient has in you, if you're saying, look, I agree with you, Mr. Patient who's come to me for cataract surgery, that you indeed need cataract surgery, but we can't do it right now. We have to do this first.
Yeah, I think most patients appreciate taking a step back and doing what's best for them. It's not without risk, okay, and it's not without some discomfort on their end. And some patients really they just want the cataract done, and that's okay too. But I think in the era of full disclosure, you do want to mention to them that they have something going on. Again, because if you tell them beforehand, then at least they have an understanding of what's going on. So if their result is not perfect, which very likely could be the case given the surface irregularity, then you have a reason for it, that they understand that they had a decision that played a role in that.
Yeah, and certainly the stakes are lower if one's not putting in a toric lens, but with a toric lens, it's not impossible to get burned very badly.
Yeah.
Sam, I want to thank you very much for bringing this important topic to us, for sort of counseling patients and counseling our patients in managing people to optimize them first, and particularly before the biometry. And as always, for being so very generous with your time with us today.
Thank you.